Hello, everyone, and welcome. Good afternoon. My name is Greg Wahlstrom, and welcome to the Healthcare Executive Course 2017 Population Health Management, entitled 3 Secrets to Value-Based Purchasing Success in Healthcare. We are pleased Beta Home Health Care and DXC technology experts have joined forces with the Healthcare Executive around this important topic of bundled payment, focusing on quality care within the healthcare landscape. We would like to especially thank Stacy Klinker, one of our consultants here at the Healthcare Executive, who has played an integral role in the development of this value-based purchasing program. We would also like to especially thank Dr. Mangat and Dr. George Matthew for their continued support with our Population Health Division at the Healthcare Executive. After today's webinar, you will be directed to a short survey, which our team hopes you will take the time to fill out. If any IT problems arise, please visit gotomeeting.com/meeting/online-meeting-support for further assistance. As we begin the presentation, can you please mute your telephone lines until the question and answer portion of the event? On the right-hand side of the webinar platform screen is a text box to write a question to the presenters. If you have a general question, please insert your question into the text box. If you have a specific question for one of the presenters that you would like to ask, please insert his or her name next to your question. Just as a reminder, this webinar is being recorded. We are excited to announce that we have an audience who is listening here in the United States and abroad. Our team at the Healthcare Executive is privileged to be able to partner with Beta Home Health Healthcare and DXC Technology on this important program geared around value-based purchasing success within the healthcare sector. Healthcare is changing now more than ever, and we pay for the care that is no exception. Given that healthcare spending is 17.8% of our national GDP, the U.S. government is looking for different methods that will help reduce spending. There are several different models in place, including comprehensive joint replacement for the new cardiac bundle and bundled payments for care improvement developed by CMS as a possible solution. With the new bundled payment model, providers are compensated for an episode of care, placing an emphasis on quality of care and cost controls. But what does this payment model mean for patients and providers? This program will examine some of the types of payment models, the benefits and drawbacks, and what potentially lies ahead. Some of the topics that we will discuss this afternoon are bundled payments for care improvement, comprehensive care for joint replacement, as well as advancing care coordination through episode payment models, integration post-acute care in the bundle strategy, role of bundled payments in improving quality and reducing costs, and the role of outcomes measurement in bundled payments. We will also cover challenges associated with bundled payment expansion, as well as brief overview of other value-based models. We will cover episodes of care and what will be bundled next. Will bundled payment models remain given uncertain of the Affordable Care Act? And will bundled payments lead to more proactive planning to reduce post-acute care costs? And finally, implementation challenges moving forward. We would like to especially thank Stacy Klinker for her continued support with the value-based purchasing program. And today's moderator, Greg Wahlstrom, MBA, HCM, President and CEO at the Healthcare Executive. Greg Wahlstrom is a results-oriented senior healthcare executive with more than 18 years of broad background in business, healthcare, and human services, and has an extensive operational and administrative expertise. He is currently the President and Chief Executive Officer of the Healthcare Executive, leading organizational performance assessment in multiple program areas, followed up with customized C-suite healthcare training that speaks to identified needs. Greg has delivered focused programming around key elements to achieve success based upon best practices and emerging best practices that show promise of improving healthcare organizations nationally and internationally. He has led webinars and face-to-face webinars for thousands of healthcare administrators and executives through the American College of Healthcare Executives and the Healthcare Executive. Prior to the Healthcare Executive, Greg worked as an assistant administrator, director of social services, and a behavioral health case manager. Greg received a master's degree in business administration and healthcare management and a bachelor's degree in business administration from the University of Phoenix, and he has also completed studies abroad at Shanghai University in Shanghai, China. He is a member of the American College of Healthcare Executives, and Greg is also the current immediate past chairman of the Healthcare Executive Education Committee for the Central Illinois chapter of ACHE. Now I'd like to take the opportunity to introduce the panelists for today's program. Dr. Mandeep K. Mangat, MD, MPH, Chief Strategy Officer, Senior Consultant at the Healthcare Executive and Beta Home Healthcare. Dr. Mangat is a Chief Strategy Officer at the Healthcare Executive and a Senior Consultant of Population Health Management at Beta Home Health Practice. She directs the ongoing implementation and coordination of population health initiatives aimed at enhancing quality of patient care and clinical outcomes. Mandeep has held several positions during her clinical career, including general physician, and public health professional, director of general medicine department, and administrator of population health and clinical integration. She has over 16 years of extensive healthcare experience in hospital medicine, home health, clinical operations, population health, and operational efficiency improvement in both acute and post-acute care settings. Her interests include outcomes management, results-driven continuous improvement, and multi-level determinants of population health. She received her medical degree, MD, from St. Petersburg Medical Academy, master's degree in public health, and PhD degree with a focus in healthcare administration from Westchester University, and a Lean Six Sigma Healthcare Process Improvement Master Certification, LSS, from Villanova University. And our final presenter this afternoon, Dr. George T. Matthew, MD, MBA, FACP, CMQ. George Matthew is the Chief Medical Officer for the America's Federal Business for DXC, the newly merged entity between Hewlett-Packard Enterprise Services and CSC. In the role, Dr. Matthew serves as the HPE clinical expert and healthcare thought leader to our healthcare clients in transforming the healthcare marketplace. His experience includes consulting, technology development, and business development work at GE, Goldman Sachs and Company, WebMD, Pfizer, and Aetna. Dr. Matthew brings a strong technology focus to the role, having found a healthcare technology startup career early in his career, and advises several healthcare IT startups through the Health 2.0 New York City community. Dr. Matthew graduated from Boston University School of Medicine's Accelerated BA/MD program and completed his residency in internal medicine in Greenwich Hospital, Yale University in Connecticut. He also holds a Master's of Business Administration from Duke University, Uga School of Business, and Dr. Matthew is board certified in internal medicine, clinical informatics, and medical quality. Dr. Matthew also currently serves as the member of the CMS Office of the National Coordinator, Health Information Technologies Joint Commission Consumer Task Force. He is based in New York City and continues to practice medicine as a hospitalist at Westchester Medical Center in Valhalla, New York. It is great to have all these experts with us this afternoon, and we'd really like to give our gratitude and appreciation to the panel for taking time out of their busy schedules to share with the audience a little bit about the new models related to value-based purchasing and bundle payments. So now I would like to take the opportunity to pass the floor over to our first presenter, Dr. Mangat. Good afternoon, Dr. Mangat. Thanks for joining us today.
Good afternoon, Greg. Thank you. Thank you. I would like to take an opportunity to thank you all for being here today. And today we are going to be talking about bundled payments. for care improvement. As we know, in the past, healthcare providers were paid primarily by volume of patients and services rendered, which had weaker correlation to the outcomes. Under a value-based system, healthcare organizations are rewarded for the care that produces the best possible outcomes for the lowest possible cost. Bundled payments are central to such a system. Under bundled payments, providers are paid a set amount for an entire episode of care. They either share in the savings or absorb the extra costs associated with complications, extended length of stay, or readmissions. So we'll start off our discussion with an overview of bundled payment for care improvement, or BPCI model. BPCI initiative was developed by Center for Medicare and Medicaid Innovation. The initiative is comprised of 4 broadly defined models of care. These models link payments for multiple services beneficiaries receive during an episode of care. So the organizations enter into payment arrangements that include financial and performance accountability for episodes of care. These models may lead to higher quality and more coordinated care at a lower cost to Medicare. In first 3 models, payments are reconciled retrospectively, and in the 4th model, payments are determined prospectively. So models 1 and 4 define the episode as acute care hospital stay. Model 3 covers only post-acute care, and Model 2 covers both acute and post-acute care. The most popular models are 2 and 3, with approximately 600 participants and 800 participants. So the comprehensive care for joint replacement model, or CJR model, so this is the CMS's first mandatory reimbursement model of its kind, and it focuses on hip and knee replacement. About 800 hospitals across 67 markets are participating in CJR, which took effect April 1st, 2016. In CJR, an episode begins from the time a patient is admitted to the surgery through 90 days post-discharge. Depending on the participant hospital's quality and spending performance, the hospital may receive an additional payment from Medicare, or the hospital may be required to repay Medicare for a portion of episode spending. So the CJR model, in a way, holds participant hospitals financially accountable for the quality and cost of a CJR episode of care, and they incentivize increased coordination of care among hospitals, physicians, and post-acute care providers. To succeed under CJR, participating hospitals have to make structural and cultural changes, such as empowering physician leaders to drive changes, developing metrics that quantify operational, financial, and patient satisfaction improvement opportunities, and also optimizing care management processes. If your organization has taken on risk, then you are financially accountable for patient outcomes that occur long after the patient is discharged. Controlling costs within your organization is challenging enough. So how can you reduce spending after the patient leaves? And that's the question that everybody is trying to answer. The future of care delivery is in full continuum integration. Post-acute care providers are definitely partners in the cost reduction. Many health systems have begun to focus on post-acute care as source of cost variation and an opportunity to lower episodic spending. To build a post-acute network, it may help to assess the effectiveness and quality of post-acute providers that you currently work with. Also, it might help to evaluate others in the market. You may want to consider metrics such as readmission rates, adverse event rates, and time to admit. And once you identify which providers would make high-quality partners, invite them to participate in your network. And obviously then the work to educate care managers and discharge planners about your preferred providers begins. Also, a lot of organizations may want to reconsider traditional care pathways. For example, just because joint replacement or CABG patients have always gone to SNF, for example, doesn't mean all joint replacement or CABG patients have to go to SNF. We need to think about better matching our patients to the settings based on their individual level of need. If you own post-acute settings, you should include them in any system-wide planning sessions to set strategy for care delivery under the bundled payment models. Several case studies of bundled payment models show significant cost savings among hospitals and both public and private health insurers. To give you an example, Baptist Health System, which consists of 5 hospitals located in San Antonio, Texas, undertook a bundled payment model for joint replacement surgeries. So the healthcare system insured 100% of their fees under Medicare rates while rewarding surgeons with the opportunity to earn bonuses up to 25%. So the health system sent summaries of cost and quality data to physicians to show them opportunities for cost savings and quality improvement. 2 standards for quality care benchmarks were used, one for individual physicians and another for the entire group. And so this gave high-performing physicians a stimulus to help their teammates in improving quality of care and meeting cost reduction benchmarks. Baptist Health was able to garner $6 million in cost savings, or $284 per joint replacement surgery in the bundled payment model. So bundled payment models have shown significant cost savings for hospitals, for public and private health insurers. The need to track and improve provider performance makes quality measures one of the most important constituents of an effective bundled payment program. With bundled payments focusing on care episodes, we need to identify care gaps, optimize care coordination workflows, and better manage transitions of care. So to maximize our returns from bundled payment programs, we need to effectively track not only clinical metrics such as hospital readmission complications, hospital-acquired infections, but we also need to look at financial and operational metrics. And this helps us identify performance and quality of care gaps and then refine care bundles to improve performance. Sometimes just knowing where you stand in terms of the data and then being able to have the courage to admit where you have room for improvement can make a huge difference. So in terms of challenges associated with bundled payment expansion, so there are situations when using a bundle may be inappropriate because the factors that are influencing differences in cost among patients are things that the provider doesn't actually control. For example, you might have a range of patients who have different comorbid conditions, and some of them are very high risk and hence would be very expensive. And that's not really the fault of provider. And sometimes there are things that can be controlled by providers, and sometimes you just can't tell. And that's what really makes things complicated. There are other obvious challenges, and those include, those are the things that come with making such a big transition. You need infrastructure, data, reporting that were not necessarily needed in fee-for-service world. There is also a possibility of healthcare underuse. So while fee-for-service payment system incentivizes healthcare overuse or unnecessary wasteful medical spending, bundled payment models could actually lead doctors and hospital workers to underuse some needed treatments or tests or diagnostics. If we think of the spectrum of value-based reimbursement, we go from fee-for-service, pay-for-coordination, pay-for-performance, which are relatively low risk, and then we move towards higher risk spectrum with bundled payments, shared saving programs with upside and downside risk and capitation. For a healthcare organization, the move to a pay-for-performance model could be a first step towards taking on more aggressive risk-based contracts. Early success with pay-for-performance can pave the way for shared savings or capitated agreements. Accountable care organizations are groups of doctors, hospitals, and other healthcare providers who come together to give coordinated, high-quality care to their Medicare patients. The goal is to ensure that patients, especially the chronically ill patients, they get the right care at the right time while reducing unnecessary duplication of services and preventing any medical errors. When an ACO succeeds both in delivering high-quality care and reducing spending, it will share in the savings it achieves for Medicare. So there is Medicare Shared Savings Program, which helps the Medicare fee-for-service program providers become an ACO. Right now, there are 3 tracks for ACOs in Medicare Shared Savings Program. Most are in Track 1, which gives participating physicians and other providers a chance to make extra money without any risk of losing it. ACOs in Track 2 and 3, however, come with downside risk, and therefore they qualify as advanced APMs. Advanced Payment ACO model is a supplementary incentive program for selected participants in the Shared Saving Program. And then there's a Pioneer ACO model, which is a program which is designed for early adopters of coordinated care. Medicare is also encouraging coordinated care through Comprehensive Primary Care Initiative, CPC, which is a 4-year multi-payer initiative designed to strengthen primary care. It focuses on access, continuity of care, planned care for chronic conditions, preventive care, patient-caregiver engagement, and it also takes into account risk stratification, coordination of care. Participating primary care practices receive 2 forms of financial support on behalf of their fee-for-service Medicare beneficiaries. One is a monthly non-visit-based care management fee. They also have the opportunity to share in any net savings to the Medicare program. CPC also serves as the foundation for Comprehensive Primary Care Plus, CPC Plus, which is a 5-year advanced primary care medical home model launched in 14 regions in January of 2017. Now, at this point, I would like to hand it over to Greg. Greg?
Thank you, Dr. Mangat. Thank you for sharing a wealth of information. I've learned a few things that I did not know related to value-based purchasing. I'd like to take a brief moment to reflect on your presentation and ask a couple questions related to your discussion. Could you share with the audience how reimbursement can be adjusted by region?
That's a great question, Greg. In the past, bundled payment programs, patient complexity didn't really matter because hospital payments were based on a comparison with hospital's own past pricing, which already reflected the complexity of the patient population that it served. Now, under new models of regional comparison, complexity becomes irrelevant, and so we need risk adjustment. Let's take an example of CJR. CJR pays hospitals a set bundled amount for the full range of care provided to a hip or knee replacement patient, rather than paying individual bills for parts of that care that could be operation, hospital stay, care after hospitalization. Reconciliation payments then reduce payments to hospitals if their spending is above a target, and increase payments if spending is below a target. So previous bundled payment programs have based reconciliation payments on a hospital's own past performance, but under CJR, those payments gradually become based on a comparison with hospitals in a wide region. And this may result in more penalties for hospitals that care for more complex patients. But changing the program to account for patient complexity would dampen this impact. So if a program used a standard measure to adjust for patient complexity, then the hospital can hold on to more dollars per year. I hope that answered your question.
Sure. Thanks for the feedback on this payment perspective for reimbursement as it relates to bundle payments. I'd like to propose one more question before we pass the floor over to Dr. Matthew. With all that you've mentioned, do you think that this will lead to integration of post-acute care services?
I think this is already leading integration of post-acute care services. 4 of every 10 Medicare patients are discharged to post-acute care. And post-acute care is defined by CMS as home health, skilled nursing facilities, inpatient rehab, long-term acute care hospitals. Most Medicare patients are discharged to home health and SNFs. So in order for hospitals to win under bundled payment programs, they have to take a more proactive role, working with healthcare teams to plan the discharge of the patient a little bit more carefully. So the challenge is making sure they have good relationships with post-acute care providers. So bundles are putting hospitals at financial risk for managing quality and efficiency of care delivered by those post-acute care providers. So if you're responsible for 90 days, you can't say the patient is discharged, that's not my responsibility. It actually forces providers to have closer interactions and relationships about the care of the patient with anyone who touches that patient over a 90-day period. And this is certainly leading integration of post-acute care services.
Thank you so much, Dr. Mangat, for sharing your both thoughts with us. Now I'd like to take the opportunity to welcome our next presenter this afternoon, Dr. George Matthew. Good afternoon, Dr. Matthew.
Hi, Greg. Thank you for the introduction. So, and Dr. Mangat, thank you very much for going through the fundamentals of how the programs work, because I think for a lot of people, the complexity of how that works and how it affects them escapes many, including myself on occasion. So I wanted to say thanks for that. In terms of how episodes of care are going to be approached going forward, and Dr. Mangat, you may have already said this, I just wanted to reiterate it for folks. People should understand that prior to the election, the pilots that were involved with doing this type of bundling of care were voluntary. Going forward, and this is where there has been some consternation on the part of providers, CMS had originally proposed that this type of bundling of care for payment was going to be required. And that's a key difference, because when you start talking about the revenue mix for a lot of these folks, how it impacts their business and whether they want to participate or not, it could make it have a huge impact on many of the specialties involved. For the ones that we've talked about that will be impacted, the most work, again, has been discussed earlier, has been for joint replacement. The current program is now being expanded to repair hip and femur fractures, where before it was a little more limited. I think the real change, though, is also going to be with for bypass surgery and heart attacks, the cardiac bundle. What's been going on in terms of that has been looking through the pilot data that's been reviewed over the last 2.5 years now, and determining, are the savings and the outcomes where we want it to be. The Federal Register that came out had delayed the final announcement for that to March 21st for the final rule to require people to do it. And part of that had to do with the new administration coming in. When Secretary Tom Price was nominated and put into the position, as a senator, he's always been a long-term opponent of a lot of the Affordable Care Act and some of the reforms, not so much in principle, but more in the sense of how it was accomplished. I think he's gone on record several times saying that many of the stakeholders, such as providers, were not 100% consulted given their full input into the rule, which is why he originally had come out saying that he would rescind a lot of the final rules for the mandatory involvement. Again, there was some talk also because Dr. Price is also an orthopedic surgeon by background, having practiced for, think about 20 years. And the first rule, the joint replacement rule, of course, affected orthopedic surgeons. However, the final rule, even though delayed, is still expected to come, to kick in. I think it's July 1st for the cardiac measure. And I think the goal, again, as Dr. Mangat very eloquently put, is to move from volume or fee for service to value or outcomes based. I think the real push is going to be on whether the outcomes are there, as the use of quality measures will also be used to assess how effective many of these programs are, and whether how that will balance with cost savings. Since it seems that in the earlier pilot, when they were looking at the results of the program, in the orthopedic surgeon, or rather the orthopedic bundle, the savings were calculated to be, I want to say, in the $500 to $600 range per patient. Sorry, it was $864 per unit per episode for those providers that had volunteered and used the second model. And this was the model that involved patients being in the hospital all the way through discharge, post-acute care, and potential readmissions. So again, statistically significant. In contrast, for those hospitals that were involved with cardiovascular surgery episodes, and this is where the second bundle comes into play, they really didn't show any savings, at least not significant. And again, this is preliminary data. They're still reviewing over it. But they were able to maintain quality of care based on the quality metrics used, and that data was enough for them to, again, continue the program as part of the 5-year pilot and move it to this mandatory status. So I think it's important for everyone to realize that the horse is out of the barn. We are moving to value-based care, and we'll have to keep an eye on what the actual focus or priority will be for the administration as to how they reimburse things. Will it be for outcomes and then cost, or cost and then outcomes? And again, the tricky thing with anything outcomes-based is the fact that a year or 2 years, which is how many of these things are assessed, isn't enough time or data to really assess the success of a program, right? So let's talk about challenges moving forward. And again, Dr. Mangat did an excellent job talking about what a value-based program, be it an ACO, a PCMH, or whatnot, has to put in place. But in terms of implementation of getting this done, especially now that these are mandatory, a couple of things, many of which overlap with what Dr. Mangat had said, apply. To be able to do or deliver on this type of bundled payment plan or any type of payment innovation program, you need to have a very robust IT system. And you need to have interoperability, not only within your hospital or healthcare system, but anything that it touches. I think, as Dr. Mangat had said, with Model 2, when the provider is held responsible for the entirety of the healthcare system, and anywhere the patient can touch, that means they need to have as close to real-time data as possible, as well as advanced analytics that can allow them to risk stratify patients, so that when a patient touches the system, providers and anyone that's involved with that patient already has an idea not only of what this patient's history is, but potentially how they will interact with the system and how to construct supports for them so that they don't fall off and eventually impact their outcomes. As for the patient-centered medical home concept, again, a lot of this puts a lot of the onus on the provider. Providers themselves, and Dr. Mangat and any other physicians on the call can verify, look, I went to medical school. I never really learned how to do risk stratification, unless I went for a master's in public health. I definitely know nothing about costing or paying for my patients or what it costs them. This isn't something I ever learned in medical school. That is actually going to have to change, because as providers start becoming more involved with value-based care, in some ways they take the same responsibilities as a fiduciary would, or somebody advises you on your investments. How that will happen and how that'll transition, I'm not sure, but that's definitely going to have to be solved for many providers because that's not an approach that they've normally been trained in. Then as we start talking about IT, obviously we have to start talking about data. Without the data from patients, from providers, from pharmacies, from hospitals, none of this works. And we have a lot of things in place that prevent open data sharing, some for very good reason. HIPAA obviously comes to mind, and the penalties involved with it, especially if there's a data breach. But because of the lack of data sharing agreements as well as security, honestly, people don't think about security until the last thing when it comes to IT implementation. So as a result, when there's a breach or when somebody leaves a laptop or when somebody holds a hospital ransom, a lot of these healthcare systems are basically left vulnerable and then have to pay these things out. And a lot of patients' data is then lost. And as a result, it makes constructing something like a value-based program very difficult. And last, but again, Dr. Mangat expressed this very eloquently, provider and hospital agreements. There has to be some type of give and take between the system so that when there's a handoff between the provider and the hospital or the hospital and a post-acute care system, that patient doesn't get lost along the way because otherwise it leads to potential repeated tests and redundancies or misdiagnoses or other things that add waste to the system. So these are just some of what I consider to be some of the major implementation challenges to building one of these programs effectively. Greg, I'm going to hand it back off to you.
Sure. Thank you, Dr. Matthew. You shared a great wealth of information and some great takeaways from your presentation. If you don't mind, I'd like to follow up with a couple of brief questions. The first question is how do new models reduce costs for patients, hospitals, and third-party payers and create uniform product to allow for increased competition?
A lot of this, again, Greg, I'm going to oversimplify just for the sake of the call and keeping it brief.
Sure.
A lot of this is variations on capitation, right? We're giving you a fixed amount of money to figure out how you're going to take care of this patient. It's obviously been tried in the past. Back in the 80s, it was the big thing with health maintenance organizations kind of taking over the country. It's obviously been revitalized in some ways, in multiple different ways, to recognize the fact that, again, in the end, as the United States, we value a free market, and we want to try to preserve as much free market spirit and competition as possible. So, that kind of goes against the grain when you're talking about standardization, offering a one-size-fits-all solution. And I think that's where a lot of this comes. This type of model, if you look at it from a capitation lens, gives you a fixed amount of money. And then it's up to those stakeholders, hospitals, providers, ancillary services, to figure out how to dole that money out properly. And in return, that kind of pushes them to then strike more efficient contracts, if you will, with their subcontractors. So anyone that they're doing business with, they're passing on those potential discounts or savings or lower fees to them and ultimately to the patient. Does that make sense?
Yes, sir. Yes, sir. Thank you, Dr. Matthews. Thanks for sharing that. One more quick question before we open up the questions for the panel. How do you define episodes of care when multiple conditions interact?
Yeah, it's funny you mentioned that. I was looking through some of what we were talking about, and that's always been a weakness of episodes of care. Typically, for the episodes, and many of the ones here, it's typically one condition. And as anyone in healthcare knows, it's very rare. It's there, but it's very rare to find that very sick patient only has one condition. There are movements, I think even at CMS, to try to have more than one condition. I think they even have it as one of their key chronic conditions where they actually have the access defined for 2 or more conditions. But, when you run into the issue of, especially when you're doing data analytics, too much complexity, where it gets to the point where you have so many conflicting data points that you can't really find a signal to determine which is the factor. So, as far as I know, and again, it may be out there, I just haven't encountered it myself in terms of people successfully combining multiple episodes of care and then being able to implement it within a state program. We're still in the early stages, or you can say the early innings of a game. I think we need to basically reevaluate what we've done with our bundles so far, and then once we've got those episodes figured out to a certain degree, that's when we'll start adding complexity with additional multiple conditions or chronic conditions. Again, there's plenty of people out there with it. We just have to get our science to catch up to it.
Thank you so much, Dr. Matthews. Now I would like to open up the floor to questions to the entire panel. So Dr. Mangat and Dr. Matthews, feel free to chime in on this first question. Whether or not bundled payments cause an avoidance of high-risk patients or deter ordering necessary but expensive tests. Could you tell us whether or not bundled payments cause an avoidance of these?
I have to say I'm not sure. When you look at earlier models that have tried to do something like this in terms of incentivizing providers, say pay for performance, obviously that's always been a big concern, where if providers are incentivized based on just their quality measure performance, and they have a very high rate of sick people in their risk pool, that they're always going to be penalized for that. The concern with that is that they would start cherry picking better patients or well patients, and those that really, really need the help wouldn't get it. Is there a risk of that with episodes of care and capitated payments? Yeah, there is a risk, especially if we're talking about standards across the country. But I do know, at least from the CMS perspective and others, they are trying to move towards risk stratification based on non-health risk factors, geolocation, that type of thing, cost of care in the area. These factors also will affect how these payments go out, and they're trying to account for that. Is it in the current system? Not as much as they'd like it to be, but they are working trying to incorporate that in. I hope that answers it.
I would just like to add to what Dr. Matthews just pointed out. I think in the future, as we continue to evolve with these bundles, I think the bundle payments should be tied to achieving the outcomes that actually matter to the patients, instead of just looking at some metrics that we think are important, such as readmissions at a population level. Maybe it's of no use to a particular patient. If we can tie those outcomes to what matters to the patient and take into account any differences in patients' age, health status that affects the complexity, and cost of treating a particular condition, and also take into account the population health, social and living circumstances, and those social determinants of health that are so important. I think if they all are reflected in bundled payment in the future, then we wouldn't have a case where we think that, providers will be looking at cost avoidance in terms of taking in high-risk patients or ordering expensive tests. Obviously, we definitely don't want to cover unnecessary services or inefficient care, but if we take into account all these determinants of health and build a bundle that reflects changes in payments based on those, we would have more success in the future with bundles. And also, more providers would be happier to join into bundles. In our markets where we are, sometimes they get into mandatory bundles, but voluntary bundles are still a problem, and everybody looks at it as an expense, as something that they are not comfortable working with at this moment. So that would alleviate some of the concerns that providers have overall.
Thank you, Dr. Mangat. Another question for the panel is, how non-compliant patients impact cost? Can you guys expand on that?
Sure. If we're talking about a chronic condition where somebody, let's take diabetes, right? That's the prototype that everyone always talks about when we're talking about chronic conditions, that and high blood pressure and cholesterol, of course. For those patients that are out of control with their diabetes management, right? These are people that, have been given a course of action to take, have been referred to a dietitian, have been referred to, been given advice to do more activity, and they refuse to do those things. Ultimately, as you go through their longitudinal health pattern, it gets worse and worse over time. For the quality metrics that a provider would be assessed on based on the performance of that, again, the ones that come to mind, and Dr. Mangat, you probably know it better than me, but, what's your hemoglobin A1C level? Have you gotten an eye test done to make sure that you don't have retinopathy? Those are the few that come to mind. There's a few more, obviously. I'm, of course, quoting the ACO measures or the PQRS measures. But I guess the thing is, if it's linked to some type of episode of care, or it's linked to quality measures in episodes of care, that would negatively impact the reimbursement for that provider. Again, long drawn-out answer to pretty much an obvious one, but Dr. Mangat, what do you feel about it?
I agree with everything you just said, Dr. Matthew. It's difficult because, in our practice, we try to not stay non-compliant because we don't know why they are non-compliant, or even if non-compliant is the correct word to use. Patients may be forthcoming about more practical challenges, but they usually are not very forthcoming about psychological barriers, which are difficult to identify, difficult to articulate. They usually don't tell their physicians that every time I look at that pill bottle, it reminds me that I'm ill, or, I feel better today, so I thought I didn't have to take medication. At some point, if we end up developing programs that improve adherence and find balance between customized interventions and effective programs that would work for individual patients and also work for classes of patients, I think at that point, maybe we can impact the cost in a positive way.
Those are all points. Okay, definitely. Because, again, this goes to the point I was making about social determinants of health. Most of the time, what people don't usually know about is when people say they haven't taken their medication. If you had longer than a 15-minute visit with a patient, you could ask them, so why didn't you fill your script? And you would get, one of several answers. It's very rarely, I didn't want, a lot of the times it was, I couldn't afford it, because it was either that or food. I had trouble administering it to myself, or I didn't have transportation to get there, or even here to this visit. And there are things that are non-medical or non-voluntary, really, that affect it. And I think a lot of the government is trying to recognize that to a degree. And obviously the behavioral health determinants, before I forget too, because that also affects your other clinical health. The government's trying to address that and figure out how to recognize it. But I think this is where we talk about the danger of using proxy variables to determine health. When you look at your typical episodes of care, the only data we really have to build a lot of that currently is claims data, which is all payment-based. When you look at quality measures, again, that's claims or clinical data, but it's all based on a proxy of, did they get a pill? Have they seen a doctor? How is this lab result? It doesn't really link as well to some of the factors that Dr. Mangat actually listed. And I think as we move forward, there is going to be, because this is some of what we've talked about at the ONC as well, as long as we can anyways. The idea of having some type of shared incentive with consumers, with patients, where they can evaluate themselves. They also can share in some of the benefit, short-term as well as long-term outcomes benefit with the provider, may be a way forward so that they can start working together as a team. Sorry, Dr. Mangat, I didn't mean to jump in on you at the end, but I was very excited what you had to say.
No, it is. You have put it so eloquently. I think you summed it up so well. One of the things that we've noted in our practice as we go out and work with health systems to integrate care with post-acute, you found that in most of the contracts, we still have very little usage for social services. And for some reason I feel, and this has been tested with heart failure patients specifically, a population that we were working on for quite some time, that if you increase the use of social workers, that can impact readmission rates, impact social determinants, because they are solution finders. They walk in and they do a scan of the environment, they talk to people, they have special skills that we as clinicians, especially physicians, I mean, we weren't taught in medical schools communication skills to the extent how to talk to the patient, the caregiver, get information from them, or informational interviewing, or other skills that social services have expertise in. And I think involving those groups in the care of patients can really help. And this is something that we have to think about when we are talking about bundling and involving all kinds of providers.
Thank you so much for sharing that. I know, Dr. Matthews, I asked you about how the new models of bundled payments reduce costs for patients. But I was wondering, could you tell us a little bit about what the episode of care will be bundled next? Do you have any thoughts or opinions on that?
You mean the cardiac rehab, the new bundle that they're trying to put out going forward?
Correct.
Sure. Again, just to, I'll give it the high level, since a lot of it actually comes down to the rehab afterwards, as well as the surgery itself, and linking them together to see how well people can save money on it. I mean, I think that's one of the major concerns that a lot of the hospitals have out there. Cardiology as a business line has been a huge moneymaker, if you will. For those hospitals that spend a lot of money on that, or make a lot of money on it, it makes it a little bit more difficult to make money on this. As we said, bundled payments typically give you a fixed capitated rate. These hospitals, which before could just bill and charge for whatever they wanted, now would have to integrate with a lot of the post-hospital cardiac rehab, any readmissions that have afterwards, which of course is under them, and any providers, and make sure that those patients, which before weren't their concern, now are all falling under that capitated payment. And I think, as Dr. Mangat had mentioned, many may or may not have developed the relationships they need to ensure that that doesn't happen.
And then one more question is, will bundled payment models remain given uncertainty under the Affordable Care Act?
It looks like they will at this point. As I said, Tom Price, the Secretary of Health, had said before that he was interested in doing away with them initially. That hasn't happened. In fact, a lot of the reforms so far have, or I should say, under the Affordable Care Act, have stayed. That's not to say that they couldn't be pulled in the future, but again, if I use the analogy of the horse being out of the barn, a tremendous amount of money is being saved by the government by pushing from volume to value. Even if they decide they're going to do away with some of the reforms, I believe the amount of money they feel they can save with this is too great for them to say that they won't do some type of bundled payment in the future. They will probably keep it. It's just a matter of how.
I agree with Dr. Matthew on this one. I think that any changes may very well preserve the bundled payment models, but they might make them voluntary. And I do think a voluntary process of bundled payment is a train that is already going down the track. We've been hearing it from providers. That's something that they are excited about as well. But the episode payments are here to stay, regardless of a mandate, because of the multidimensional value that they generate. Health systems that will continue to invest in strong care management across the continuum, they will succeed regardless of any changes that are coming for us.
That makes sense, Dr. Mangat. I mean, yeah, I mean, in the end, they do feel that there's a benefit to it. And I think the real sticking point for Price and many providers was the fact that it was mandatory versus voluntary. If it is made voluntary, and again, as you said, that there is talk about that, that should give providers enough breathing room to figure out how to navigate this new world, get their systems in place, and then try to find a way to competitively participate.
Absolutely.
Now I'd like to take the opportunity to open up the questions and answers from the attendees. On the right-hand side of the webinar platform screen is a text box to write a question to the presenters. If you have a general question, please insert your question into the text box. If you have a specific question for one of the presenters that you would like to ask, please insert his or her name next to your question. One question for the panel is, will bundled payments lead to more proactive planning to reduce post-acute care costs?
It should. I mean, if it's, depending on the model, if it involves the post-acute piece of it, yeah. I think it will depend on those agreements that we had talked about before, that the post-acute provider, the hospital, and the provider are all comfortable with the split of the payment. And if they're willing to hit certain benchmarks operationally as well as clinically, then yes, it should over time.
I agree with Dr. Matthew. I think the hospital systems usually have an incentive to reduce its, the costs. And for example, the joint replacement, total for joint replacement when it falls below Medicare fixed reimbursement level, the gap being the hospital's profit margin, hospitals have incentive to rein in any kind of overuse of expensive follow-up care in post-acute settings. And so hospitals are, taking great measures I've seen in market to improve care coordination, improve care management, and data is a huge part of it. And it's probably the challenge as well, because a lot of organizations are still not able to in a meaningful way share the data that they want to share. So we still can't see reports, for example, from a hospital system on our EMR and vice versa. So that interoperability is definitely a challenge, but everybody is working towards making sure that the costs are low. And as the post-acute care facility, I know that we are judged depending on how much cost savings we generated for the health system as a whole.
Thank you, Dr. Mangat, for sharing that. And then one general question, what do you forecast as implementation challenges moving forward?
I mean, there's a few. I think the interoperability point, which Dr. Mangat kind of hinted at, is a big one. As a lot of these provider organizations, defining provider organization as being a combination of physicians or physician extenders and hospitals, just to define it for the call. As these organizations expand and start gobbling up more practices and more hospitals, it becomes tougher and tougher to integrate between all these different organizations. In some cases, it's gone to saturation. But as you start including in post-acute facilities as well, being able to collate all that information into something that can be analyzed and made sense of becomes a much more challenging proposition. And, again, to pull the analogy of changing the wheels on the car while you're driving, this is all in context of these value-based programs going. I would say that would be one of the key challenges for implementation for a lot of these organizations. Getting the system in place where they can actually collect data accurately, risk stratify their patients, and deliver decision support to physicians care providers in the field so that they can accurately and adequately treat their patients. It's going to be something that I think will be a long-term investment, and short-term would be a loss for a lot of these organizations until they get to a certain level of development. I mean, don't forget, in the original ACO pilots that came out, I think it was in 2014, they said, I think it was 53 or 55 of the 220 that were actually in the program actually were the only ones that actually made money or stayed flush. All the rest lost and then dropped out. And that was at a savings of about $880 million to, $880 million to the U.S. government. So there's a lot that needs to be done just to fix that before we can get to a point where we can say we have a good operating system.
Thank you, Dr. Matthew. Dr. Mangat, do you have any thoughts or opinions on the implementation challenges?
Not many. I think Dr. Matthew did a great job summing it up. I think to be successful, we have to develop and adopt evidence-based care models that cross the continuum, which is standardization of evidence-based practices. So it shouldn't be that a patient, came to hospital, was told something entirely different, and then they went home health or SNFs, and then their care plan changed to an extent where, the things that they were told in hospital don't apply to that extent. I've seen that over and over. Simple things such as, weight loss parameters, for example, or weight gain parameters for maybe heart failure patients. I think that as long as we don't promote standardization in providing care and also in collecting data and then making sure that everyone is getting the same data, is tracking those metrics, I think we're going to have some challenges.
Thank you, Dr. Mangat. Just as a reminder, on the right-hand side of the webinar platform screen is a text box to write a question to the presenters. If you have a general question, please insert your question into the text box. And if you have a specific question for one of the presenters that you would like to ask, please insert his or her name next to your question. I don't see any text box questions coming across the screen. Now I'd like to take the opportunity to open the floor for audio questions. If you have a question, would you like to ask Dr. Mangat or Dr. Matthew? I don't see any text questions or audio questions coming in at this time. Here are a couple additional resources related to the development of this program. We'd like to especially thank Dr. Mangat, Dr. George Matthew, Stacy Klinker, and Greg Wahlstrom for their hard work and dedication to bringing this population health management program to the forefront. We are pleased to have the opportunity to explore some of the secrets behind value-based purchasing. Our team at the Healthcare Executives hopes you'll take the time to fill out the survey at the end of the presentation to ensure continuous improvement. And if you have any questions related to the presentation, feel free to contact info@thehealthcareexecutive.net. Also, you can reach us at thehealthcareexecutive.net. Just as a reminder, this webinar was recorded and will be available as soon as our production team has finished editing and posted on our website. Those who have attended the webinar today will be provided with a follow-up email after the recording has been published. Thank you so much for attending today's webinar, and we are now concluded.